Hello, I'm going to present my paper about a case study using the MFR or myofascial remodeling techniques. Hypothesis MFR technique can treat low back pain in a male patient. Said Safar Musavi, manual osteopathic therapist, program May 5th, 2023. Manual Osteopathic, College of Canada. Abstract. Low back pain describes pain between the lower edge of the ribs and buttock. It can last for a shorter time, which is called acute, a little longer time, subacute, or a long time, which is called chronic. It can affect anyone. Low back pain makes it hard to move and can affect the quality of life and mental well-being. It can limit work activity and engagement with family and friends. Low back pain can be specific or non-specific. Specific low back pain is the pain that is caused by a certain disease or a structural problem in the spine, or when the pain radiates from another part of the body. Non-specific LBP or low back pain is when it is not possible to identify a specific disease in a structure reason to explain the pain. LBP is not specific in most cases, 90% of the cases. An estimated 619 million people live with low back pain, and it is the leading cause of disability worldwide. In most cases of acute low back pain, symptoms go away on their own and most people will recover well. People with LBP may also experience spine-related leg pain. This is often described as a dull sensation or a sharp electric shock feeling. Numbness, tingling, and weakness in some muscles may be experienced with leg pain. In this case study, I'm going to show the efficacy of myofascial remodeling techniques applied to lumbar partition. However, I do believe that more studies need to be done with a larger group of people. Introduction. In 2020, low back pain affected 619 million people globally, and it is estimated that the number of cases will increase to 843 million cases by 2050. Driven largely by population expansion and aging, according to the WHO. LBP is the single leading cause of disability worldwide and the condition for which the greatest number of people may benefit from rehabilitation. LBP or low back pain can be experienced at any age, and most people experience low back pain at least once in their life. Prevalence increases with age up to 80 years. While the highest number of LBP cases occur at age of 50, between 50 and 55. LBP is more prevalent in women, according to WHO Global Burden Disease 2019. Non-specific LBP is the most common presentation of LBP. Recurrent LBP episodes are more common with restriction and reduced quality of life around the world. Considering the high prevalences, the LBP contributes to a huge economic burden on society. It should be considered a global public health problem that requires an appropriate response. In health facility or clinical-based studies, episode remission at 1 year ranges from 54% to 90%. However, most studies do not indicate whether the episode was continuous between the baseline and follow-up time point. Most people who experience activity-limiting low back pain go on to have recurrent episodes. Estimates of recurrence of 1 year range from 24% to 80%. Given the variation in definition of remission and recurrence, further population-based research is needed to assess the daily patterns of LBP episode over 1 year and longer. There is a substantial information on low back pain prevalence, and estimates of the point prevalence range from 1 to 0.58% and 1 year prevalence from 0.8 to 82%. Due to the heterogeneity of the data obtained by the WHO, estimates need to be interpreted with caution. Other commonly reported risk factors include low level education status, stress and anxiety, depression, job dissatisfaction, low level of social support in the workplace, and whole body vibration. A study suggests that LBP may arise from any one of a number of anatomical structures, including bones, vertebrae, disc, joints, ligaments, muscles, neutral structure, and blood vessels. Treatment for LBP depends upon the nature of the pain and whether it is non-specific or specific. Treatment for non-specific LBP include physical therapies like physiotherapy, chiropractic, manual osteopathic therapies in order to improve muscle and also treat the dysfunction, improve and remove spasm, align body. Discussion. And ability to move and resume physical activity and exercise. Psychological and social support to help people manage their pain and return to doing activity they enjoy. Reduce strain during physical work, lifestyle changes including more physical activity, health, diet, and good sleep habits. This case study is about a male who is in his 50s. He's a general labor worker. He needs to do lots of bending and flexion and extension to pick up the supplies and to drop them off. As he is required to do his job and finish his job on time, he does not use he does not use proper body mechanics, unfortunately. Client states a fall history and is overweight. For treatment, he has received various treatments such as physiotherapy, exercise, painkiller like NSAID. Client has followed a diet to lose weight, but the outcome is not significant, unfortunately. Methods. The comprehensive details of informed consent were reviewed for the client, and he was informed that results and his identity will be kept secret and confidential. The short and long-term goals were explained to him, and they were documented in his chart along with the assessed results. The MFR assessment process are as global assessment, use of the longer axis for movement up the kinetic change, fascial continuum throughout the body allows for blocks or restriction to be seen or sensed while compressing, distracting extremity. Structural assessment, standing and sitting body reading for lines of facial tension, a stroke test, sacroiliac motion, supine, common compensatory pattern rotation at each diaphragm, rib cage movement with restriction in the prone position, pelvic, diaphragm, and also the sacral rock, and the functional assessment, AROM and PROM, noting the first sign of restriction, alter movement, palpation, tenderness, and looking for the tenderness, tone, temperature, texture, and also the skin gives evidence of the stage of deeper fascial and a stage of healing. Strain around the clock, assessing the facial slide and glide loss. The loss of glide and the loss of slide and glide alters muscle balance and proprioception, leading to chronic dysfunction, loading, and listening, feel for facial drag, lesion pattern, and osseous motility patterns. And the treatment. We have two techniques for the treatment. One of them is the lumbosacral decompression. The lumbosacral decompression is very good for the low back pain as well as for the other dysfunctions such as the anterior-pelvic and the hyperlordosis. The client lying down on supine and legs extended, the therapist one hand cradling the sacrum and the other hand engaged at the spinous process L4 and L5. Wait for tissue to soften and sacrum to drop off into hand more. Then distract hands apart, slowing with tissue release. Sacrum goes caudal lumbar cephal. Sacrum will feel as if it drops and slides inferior away from the ilia and lumbar. Another alternative is the client engagement by pressing ilias medially, which opens the SI joints to help the sacrum. Another is the pelvic floor diaphragm. And this technique is also very good for the LPN or low back pain, as well as the hip pain and sacral pain. And this technique is done after following the lumbosacral decompression, reduces pelvic adhesion and torsion, and can also relieve hip pain, groin pain, low back pain, and sacral pain. Integral in posture, respiration, spinal stability. Another technique which is also good for the low back pain is the glute max. This treatment will indirectly affect the SI joints and thoracolumbar fascia by maintaining facial glide and force transmission between muscle and layers. Can also help realign sacral and coccyx torsion or maintain a correction, reduce inhibition of the glutes and low back pain as well. The technique is that the client is prone, the therapist heel of the hand engage the atrial attachment of gluteal max, the other hand crosses to engage collateral lower latissimus dorsi, option to engage ipsilateral latissimus dorsi as well. And the shaping assesses the coccyx for torsion as well. And here we have the results. The findings are right shoulder a bit lower than the left shoulder, anterior pelvic rotation on both sides, ROM limited on hip and spine, L4, L5 left rotation, Stork test positive, CCP or the common compensatory patterns, and the diaphragm is left, right, and pelvic diaphragm we have the counter nutation with on the inhalation and mutation on the exhalation. And the palpitation, we found the tenderness and also tension on the lumbar muscles as well. The discussion. Almost everybody in their life has experienced LBP. Like any other musculoskeletal dysfunction, there are factors to be taken into account, like age, environment, lifestyle, gender, job, history of past trauma, physical status, psychological mindset, and etc. They all can play a role in a role affecting outcomes, and they can all play a role in how somebody may respond to treatment. The elements affecting outcome can be the expertise and the years of the experiences of the therapist, right assessment of dysfunction, and the right and efficient treatment are very important in dealing and managing client. According to results, the following treatment session according to results, following treatment session for the clients seems to following to results, the client seems to have received benefits from the treatment of the MFR treatment. Client exhibits a better range of motion in the spine as well as the hip. The conclusion, on the other hand, following treatment sessions was also determine for the client for the next week. Conclusion. Improvements in range of motion, in the range of movement of the spine as well as the hip are due to application of the myofascial remodeling treatments along with other general osteopathic treatments and manual treatment. Also, this case study could pave the road to consider myofascial remodeling techniques as a treatment, as a way to reduce low back pain. But I do believe that more studies are necessary to be done in order to validate and verify the efficacy of the treatment. The references are from the World Health Organization, Global Burden Disease 2021, Low Back Pain Collaborators, Global, Regional, and National Burden of LBP, 1990-2020, Lancet Rheumatoid 2023, 5E316-29. Another reference is the global, again the WHO, Global Burden Disease 2029, Global Burden of 369 disease and injuries in 204 countries and territories, 1990 to 2019, a systematic analysis for global burden of disease study 2019. Another reference was I use also the Google Scholar. Other references are D. Hoy and the collaborators, Low Back Pain in Rural Tibet, Lancet 2003, and Key D. Watson and collaborator, Low Back Pain in School, Children, Occurrence and Characteristics, Pain 2002 May, and D. Hoy and collaborators, Measuring the Global Burden of Low Back Pain, Best Practice and Research Clinical Rheumatology, April 2010. Thank you.